Good morning. My name is Sameen Raza. I'm the student from Harris Health System, the School of Diagnostic Medical Imaging. Would you like to know what radiation therapy is, how it works, and what are its different kinds? And also what stereotactic body radiation therapy is, how it works, and why is it the breakthrough for non-small cell early stage lung cancer? So let me walk you through this. So first of all, what is lung cancer? Lung cancer is the tumor of the chest. It is the malignancy in the epithelium of the respiratory tract. The signs and symptoms for lung cancer include cough, usually with the blood, dyspnea, weight loss, and chest pain. Also, the pathophysiology of lung cancer starts with partial obstruction of the lung wall and obstructive emphysema of the lobe, which leads to infection of the lobe and secondary abscess formation. Then involvement of the pleura, extension to the chest wall, and inversion of intercostal nerves or bronchi occurs. Finally, it spreads into the mechanism and compresses the underlying structures, which leads to metastasis to different surrounding structures or organs. The main causes of lung cancer are tobacco and smoking. There could be other factors too, like environmental factors or exposure to toxins, but the main factors remain smoking and tobacco use. In the US, 87% of lung cancer deaths are seen per year due to smoking. Also, more than 200,000 cases of lung cancer are seen per year in the US. Lung cancer is managed by radiation therapy, chemotherapy, and supportive management. So, what is radiation therapy? Radiation therapy is when the radiations are used to kill the malignant cells inside the body. For radiation therapy, protons, neutrons, electrons, and gamma rays are required to kill malignant cells. The different kinds of radiation therapy are external beam radiation, internal beam radiation, which is also called brachytherapy, stereotactic body radiation therapy, stereotactic radiosurgery, and systemic radiation therapy or radiotherapy. So let's talk about a little bit of each of the techniques. External beam radiation is when the radiations are applied to the tumor via any external or outside source. As you can see in this picture, radiations are being applied to the tumor via a machine, and that machine is used as an external or outside source. Internal beam radiation is also called brachytherapy seeding. With this technique, radiation source is applied very next to the tumor inside the patient's body, and that's how radiations reach the tumor and suppresses the tumor over time. Systemic radiation is when an intramuscular injection is administered to the patient, and that's how the radiations reach the tumor via the blood circulation. As you can see in this picture, an intramuscular injection is being administered to the patient. The radiations then reach the tumor via blood circulation. Once the radiations reach the tumor, secretion of anti-angiogenic protein occurs, which then inhibits the growth of the tumor, and finally, complete suppression of the tumor occurs. So what is stereotactic body radiation therapy is? Stereotactic body radiation therapy is the main focus of my presentation today. With this technique, very high doses of radiations are used to kill the malignant cells. And with this technique, the radiation beams does not affect the surrounding healthy tissues. It only affects the tumor. I have the axial coronal and sagittal images of CT here, and you can see how the radiations are just affecting the tumor and not the surrounding healthy tissues here. So this is the breakthrough of stereotactic body radiation therapy, that it does not affect the surrounding healthy tissues, only affect the tumor. With this technique, different beams, intensities, and angles of radiations are used to only affect the tumor and not the surrounding healthy tissues. So stereotactic body radiation therapy is also called stereotactic ablative radiotherapy. It treats small, early stage lung cancer using very high doses of radiations. With this technique, several beams of different intensities and angles are used to accurately target the tumor. With SBRT procedure steps, the accurate volume of the tumor is measured during the treatment. And for that, CT is the best modality. CT is the best modality to get the accurate volume of the tumor. There are other modalities too that are also acquired during SBRT. For example, CT. CT is mainly used to get the density of the tumor. PET is used to measure the metabolism of the tumor, and MRI is used to see the anatomy of the tumor and to see the anatomy of the structures surrounding the tumor. So I have these axial images of CT, PET, and MRI, and you can see the PET is using contrast, and here we can see the lesions very well. With MRI, excellent soft tissue contrast can be seen. MRI is acquired to see the anatomy of the tumor and the structures surrounding the tumor. So with SBRT, targeting volume of the tumor and motion management is done at the same time. As you can see in the picture, the radiations are being applied to the tumor, but the radiations are not crossing the boundaries of the tumor. It's staying inside the limits of the tumor. As you can see, the tumor is actually moving with respiration, but the radiations are not crossing the boundary of the tumor, and they are not affecting the surrounding healthy tissues. So with SBRT, that's why they take the accurate measurement and accurate position of the tumor, and they also see the surrounding healthy structures to make sure that the radiations are only being applied to the tumor and they are not affecting the surrounding healthy tissues. So the best dose fraction and prescription that is used during SBRT is 83.2 to 146 GY of biologically effective dose, which is given in 10 to 20 fractions of GY. GY stands for gray. This is the symbol used for radiation. And this dose is given Monday to Friday, 5 days a week in 30 minutes to 1 hour sessions. And most of this time is not even taken for radiations application. Most of the time is taken to place the patients in the correct position. So here I have the axial image of CT, and you can see how the radiations are only affecting the tumor and not affecting surrounding healthy tissues. So for treatment planning during SBRT, cone beam CT is acquired at the time of treatment. With this, during SBRT, the cone beam CT is acquired multiple times during the treatment to make sure that the tumor is at the correct planned position and the patient is at the correct position. So during SBRT, when they suspect that the tumor has moved even a little bit, they move the patient remotely to ensure that the tumor is at the correct planned position. For this, they acquire cone beam CT multiple times during SBRT. So as you can see, I have axial images of CT here, and you can see how they have moved the patient remotely to make sure that the tumor is at the correct planned position. So for patient immobilization technique, daily image-guided radiation therapy is done during SBRT. With this, they make sure that the patient and the tumor is at the correct planned position for the radiations application. So they are constantly taking images during SBRT to make sure that the tumor is at the correct planned position. For the follow-up, they use CT and FDG PET together to get the best follow-up studies done and to get the best follow-up images. So here I have A, C, and D CT images. B, D, and F are PET scan images using contrast agent. The contrast agent that they have used is FDG. It stands for fluorodeoxyglucose ribose. This is the kind of sugar that only reacts to the malignant lesions. As we know that the malignant lesions, high glucose metabolism rate, this sugar only reacts to the malignant lesions. And that's how the malignant lesions are picked up using this contrast very well. As you can see, these images, bright area using FDG can be seen very well here. And here the tumor is suppressing, and here the tumor is actually gone over time. So CT and FDG PET together, they are used in conjunction together to get the best imaging and to see if the tumor is suppressing over time, how the tumor is actually suppressing over time using stereotactic body radiation therapy. CT and MRI is done to get the accurate position of the tumor and to see the exact size and shape of the tumor. The imaging for SPR, with the imaging of the SPRT 3D and 4D CT imaging is done to see the anatomical images and to see the tissue electron density for precise dose calculation. I have the coronal image of CT here. This is the 4D CT image, and we can see the bright spot corresponding to the tumor here. So 3D and 4D CT imaging is the best imaging to see the anatomical images again and the tissue electron density of the tumor. 3D and 4D PET imaging is used in conjunction with the CT to get the optimum results. So again, both of these modalities are used in conjunction together to get the best follow-up studies done. So here I have A and B, the CT axial images. C and D are PET images. C is without the contrast. D is using FDG as contrast. And you can see how FDG has picked up the hotspot very well here. So both of these modalities, CT and PET, are used in conjunction together to get the optimum results during SBRT. Image registration for SBRT is also done during the treatment. For this, multiple images are taken for precise tumor volume. For this technique, they don't even just take one image, they take multiple images and compare them together to make sure that the best volume of the tumor has been measured. Also, imaging for treatment setup and verification is done to accurately margin the tumor. So MRI is used to get the excellent soft tissue contrast. As you can see, I have the 4D image of MRI and the bright area corresponds to the tumor. You can see how the anatomy can be visualized very well with using MRI. You can see how alveoli, bronchi are visual very well using 4D MRI. So this is the best modality. MRI is the best modality to get the excellent soft tissue contrast and best resolution for SBRT treatment. This is MRI is used to actually see the anatomy of the tumor and the anatomy of the structures surrounding the tumor. So what is the goal of SBRT? The goal of SBRT is to use highest possible dose of radiation and to minimize the exposure to healthy organs at the same time. So as you can see, I have axial CT image and how radiations are only targeting the tumor, not the surrounding healthy tissues. This is the main goal of stereotactic body radiation therapy. I have some more images here. You can see how machine is revolving around the patient to ensure that the radiations are just targeting the tumor and not the surrounding healthy structures. Again, the CT image of axial CT image, radiations are just revolving around the tumor, targeting just the tumor, not affecting surrounding healthy tissues. Also, motion management is done at the same time during the treatment to make sure radiations does not cross the boundary of the tumor and stays within the limits of the tumor. So who are the candidates for SBRT? The candidates of SBRT are the patients with very small early stage well-defined tumors, the patients who cannot tolerate surgery, usually the patients with non-small cell early stage cancer. For some patients, SBRT can even replace surgery as a primary cancer treatment. Some of the advantages of SBRT are that the very high dose of radiations are used, which is given in the single or very few sessions to improve the patient safety. It decreases the overall length of the treatment. It also improves the treatment response. Also, according to American Health Association, 700 facilities in the US claim that they offer SBRT. Some more advantages of SBRT are that SBRT is an alternative to invasive surgery. It's for the tumors that are hard to reach, for the tumors that are located very close to the vital organs. It's also for the tumors that are subject to movement. Also, SBRT is currently used to treat lung, liver, prostate, spine, abdomen, head, and neck tumors. So, talking about the cost of SBRT is very cost effective. Actually, a study was done on the patients with wedge resection surgery and the patients with SBRT treatment. And the results came out that the patients who received SBRT had an increased life expectancy. So, this in turn tells that SBRT is very cost effective. Some of the limitations of SBRT are rib fractures and chest pain. Also, for centrally located tumors, it can present toxicities like pneumonitis, hemorrhage, and transesophageal fistula. So, these are some of the limitations of SBRT that could be minimized using very rigorous quality assurance program. So for quality assurance program, AAPM, ACR, and ASTRO guidelines have been implemented. AAPM is American Association of Physicists Medicines, ACR, American College of Radiation, ASTRO, American Society of Radiation Oncology. All of these guidelines have been implemented to ensure that the errors are being minimized during the treatment. The team that performs SBRT includes oncologists, medical physicists, and technicians like radiographers and therapists. So, in conclusion, SBRT is minimally invasive. It provides short treatment length, only given in 30 minutes to 1 hour sessions, Monday to Friday. It maintains safety when used with care using AAPM, ACR, and ASTRO guidelines. It also improves treatment response. Also, it avoids exposure to healthy tissues, only targeting the tumor. And it's also cost effective. So, all of these qualities of stereotactic body radiation therapy treatment in turn makes the SBRT an ideal treatment for non-small cell early stage lung cancers. So, this is all from me for today. Hope you all have enjoyed my presentation and hope you all have a very wonderful day. Thank you all for listening to me.